The process of applied functional science is the transformation of the notion into the motion.
From the Gray Institute, this is the Gray Institute podcast. Gray Institute is internationally acclaimed for its innovation, development, mastery, and delivery of applied functional science, AFS. AFS is based on scientific truth, not theory, of how the human body moves in all three planes. AFS allows movement professionals like you to apply the best, most effective, and most efficient movements to any individual based on specific needs and goals. For 40 years, through training, education, and mentorship, Gray Institute has equipped over 150,000 professionals with comprehensive knowledge in the principles of applied functional science, AFS. Whether you're physical therapists, personal trainers, athletic trainers, chiropractors, strength and conditioning coaches, physicians, physiotherapists, occupational therapists, osteopaths, physical therapy assistants, or kinesiologists, our goal is to help you become the go-to movement professional.
All right, welcome to yet another webinar by Gray Institute. Now, all these are a lot of fun in general, and a lot of fun for me, but this one's, I think, going to be even more fun because, of course, we have Andrea Wasylow with us, and we're, of course, going to be doing quite a bit of movement applications based on the topic. And so on behalf of myself, on behalf of Andrea, on behalf of Dr. Gary Gray and the entirety of Gray Institute, I just want to welcome you to another webinar. In this case, the topic is movement solutions for hip dysfunction. An evidence-based approach. And the big three topics that we're going to get after is what evidence-based practice is and how it has impacted the world of human movement for rehabilitation, performance, and prevention. The second thing we're going to cover is how applied functional science provides a structure for evidence-based practice and what this looks like for enhanced outcomes for our patients and clients. And then the third and final topic is chain reaction biomechanics and movement solutions for the hip, the anterior hip, posterior hip, medial hip, and lateral hip. But before we get into that, I just want to personally welcome Andrea Wasylow with us and give her the floor to introduce herself and kind of just lay the land of what's about to come. So Andrea, thanks so much for joining us.
Hey guys, thanks so much for having me. It is a joy to be joining you today. And I'm really excited to be talking about this and how the Gray Institute and applied functional science specifically, the thought process can really fit in well with an evidence-based model, and especially when we start talking about the hip. I think it's a great location to start in the human body and with human movement because it's easy to see how we move. It's easy to see how we apply these principles to this region, and it's going to affect everything we do. So again, thanks so much for having me today.
Well, it's a pleasure to have you, and I'm going to, of course, let Gary introduce himself, but I'm going to brag on Andrea as well. Not only is she just an amazing person, she's a dear friend of ours, and she's also a GIFT faculty member, which means she's been with us since 2007, and what she pours back into the GIFT community is second to none, and she incredibly enhances the journey, not only for us other faculty members and the facilitators, but the fellows that take part in the program. So just on behalf of that community, Andrea, we want to thank you. Gary, I think people know you, but kind of introduce yourself and give us your excitement on why this specific webinar.
Well, I'd be honored to introduce myself as a mentoree of Andrea's. I think you did a great job sharing Andrea with everybody watching. She's a blessed friend of mine. She's been my mentor for a number of years. And as you indicate, she's kind of inspires a lot of us. So it's an honor to have her with us, especially on this tough topic of evidence-based. I'm confused by it, as I'm confused by a lot of things. But when I hear Andrea talk about things, all of a sudden things become clear. So we're blessed to have Andrea. And of course, you always do a great job keeping us on task and demonstrating things well. So we're ready to rock and roll.
All right. Well, we're going to go ahead and dive in feet first just to be safe here. But of course, when it comes to evidence-based practice, that's been kind of a broken record in the movement industry with really good intent. And so I'm looking to learn a little bit more about what exactly means, but how to specifically apply it to what we do on a daily basis. So on this first rock or primary focus of the webinar, our goal is to identify what evidence-based practice is and how it has impacted the world of human movement for prevention, performance, as well as rehabilitation. So Andrea, I know that you are well-versed in this topic, you are well-researched in this topic, and ultimately just want to give the floor to you to kind of take us to the next level in understanding what this topic means.
Well, thanks, Doug. And I hope that I can try and clarify this topic for everybody a little bit. Gary, like you, I was a little bit baffled by it. My education in physical therapy and in athletic training came before evidence-based practice was even a concept that people spoke about. And so a few years ago, I was, curious about what all the buzz was about. So I ended up taking an evidence-based practice course at a college. And then I took it again recently, just from a continuing education provider, just to really understand what evidence-based practice means. Because from what I was hearing from my peers was a lot of, if there's not an article, if there's not a research study to justify what you're doing, then it's probably not something you should be doing. And to be perfectly honest, that really couldn't be farther from the truth. Once I really started digging into what evidence-based practice is, I guess the best way to describe it, if you can envision a Venn diagram with 3 circles, and the intersection of those circles is evidence-based practice. The first circle is essentially the best available evidence. So the best available research on different regions from within the physical therapy or any specific movement profession, or from anywhere really that can lend evidence to the choices that you're making. That's the first circle. And that's a constantly evolving circle. Right now, again, the idea of evidence-based practice is fairly novel, and the body of evidence is limited to what we've studied so far. And even though there's a lot of fantastic evidence out there, it is a body of knowledge that continues to grow. So there might be chosen activities, well-chosen movement choices, well-chosen treatment decisions that have not necessarily been proven through the evidence. However, let's get to the second circle, which is our clinical experience, our individual experiences as clinicians or as movement professionals. Essentially, that's the second circle. We take our experience. We've all tried different things with different individuals over the years, and we use what we've learned. We've started to recognize patterns. We've started to make informed choices based on the success that we've had in the past. And so that's the second circle. We've got the best available evidence. We have our own clinical experience, but I feel like the most important circle in evidence-based practice is the individual who we are working with. That individual's personal beliefs, that individual's personal goals, and the movements that they want to get back to being able to perform confidently and safely. That is the most impactful area in evidence-based practice that we can impart with the individuals we work with. So again, if you think of that Venn diagram, best available evidence, our own clinical experience, but most importantly, the individuals that we're working with. And if we can really make sure that we are in tune with that individual, we are doing the best possible thing we can as movement specialists in order to help facilitate the success of those individuals that we're working with.
Andrea, I think that I've never kind of thought of that visual, but I like it. Of course, I like 3 things put together in kind of a triadox, and they come together. I think Dougie also said it best. I think the whole concept of evidence-based is our heart's in the right spot. But the big question I always ask is, are we gathering all the evidence up front before we go and find a likely suspect? What I'm seeing happening is something gets stolen. We're the detectives. We come in. We automatically assume it's one person, and then we spend the rest of our clinical time trying to provide evidence through articles on that one person, where a great detective will go, no, we have to consider everything and everybody before then we look at the evidence for person A, person B, and person C. So it's almost like there's two layers of evidence, universal overall evidence that will open up the entire world to us as possibilities for the cause of a dysfunction, and what I would call a little more artificial, isolated, that, well, it hurts here, so we're just going to look at evidence here at the hip or the low back, and we forget that, well, okay, that's, yes, evidence-based, but if you're missing 95% of the world, you can be digging as much evidence as you want. You're never going to find the culprit.
Gary, I couldn't agree more. And I think that part of that comes from the desire of those people who are doing the clinical research to create, essentially, there's two different criteria. There are levels of evidence, which is just basically describes the quality of a study. And then there are grades of evidence, which essentially is the overall strength of the study. And especially when it comes to movement, in order to fit the current classifications for the higher levels of evidence, you really need to create standardized movement in order to study it, again, to fit these criteria. But what I've noticed is in order to be able to do that, we have to move away from authentic movement into more artificial movement to make it more reproducible, to make it more standardized in order to complete this level of study. And unfortunately, when we do that, we take the individual out of the equation and we really move away from the movements that these individuals need to be able to perform to feel successful in their everyday lives. And so unfortunately, I think that that's a driving force in exactly what you're talking about. What's exciting to me is that, as you spoke to, looking globally, looking at the whole individual, there's a new term that's gaining momentum, at least in the physical therapy profession, called regional interdependence, which essentially starts to discuss about the interplay between how one region of the body impacts another region of the body. Right now, they're just starting to do studies to expand beyond the joint, essentially above and below the dysfunctional region that's being studied. In applied functional science, we know that for every individual, for every movement, we're going to look from the top of the head to the tips of our toes just to figure out biomechanically how somebody might be impacting that area of dysfunction. But again, as the body of evidence continues to evolve, there is still a lot of room for this area to catch up what we've been doing with applied functional science for 30 years.
Yeah, I of course, I'm the old guy, and old guys, we giggle a lot. And when I first heard the term regional interdependence as kind of this, as you said, a relatively new term over the last maybe say 10 or 15 years, we giggled because for the last 45 years, we've been saying it chain reaction. That one region influences the other region. That's just simply a chain reaction. The problem with that is that evidence has been out for years. So when you see studies that go, well, we have to have a study to prove that maybe the hip can influence the knee. Well, back in the 70s, when we scratched our head, we called that the femur. Because it was obvious that the femur was part of the hip and the femur was part of the knee. We didn't need a highfalutin study to kind of show us some common sense that if the hip happens to move, unless I fracture my femur and don't allow any movement to happen distal to the fracture, my knee's got to move. And knowing that my femur is my knee and knowing that the knee is the tibia, it's impossible to deny the regional interdependence between the hip and the foot. And of course, when you talk about the hip, which we're going to, the hip and the other hip, as well as the hip and the back and the hip and the thoracic spine. So for 45 years, we've been talking about, the body moves regional independently and as a chain reaction. And therefore, it's on one hand kind of heartwarming to hear that everybody's saying, it seems that when my patient or client walks through the door, everything's zooming, everything else, everything's connected. But that's been out there for 45 years. And that evidence has been there for a long, long time. So we just need to be, I think, savvy enough to take advantage of that evidence.
Yep, I agree. I couldn't agree more. And it's exciting, but it's also challenging. It's one thing if somebody comes in with a part of their body that's bothering them, say their knee, and, you're essentially have been taught right along, well, let's look at above at the hip and let's look below at the ankle. It's really challenging to then have to expand your assessment throughout the entire body. The good news is I'm so excited, about 3D maps, because it creates such a phenomenal framework to be able to do that in such a quick, efficient, and effective manner, that your 45 years of experience and brilliance have really pulled that together. So there's so much potential there to help so many people using that tool, again, for that whole regional approach.
Recently, you shared with us, you had the opportunity to kind of share during a seminar just your thoughts on evidence-based. And, I'm pretty sure you probably shared your Venn diagram and the intersection and your thoughts on that. But what did you share with the professionals listening that all of a sudden you saw light bulbs go off? I always like when people share with me that, when I shared this with so-and-so, they finally got it. And I like it when they say, so I'm going to share it with you, Gary. When I shared this with them, they seem to finally get it. What kind of was that?
I feel like we used a couple of different real life examples. I think that probably one of the most powerful examples was talking about working with somebody, was a football player who was a wide receiver who needed to be able to reach the ground in order to catch a ball that was thrown low. And in that example, we talked about different approaches and different ways to train the hamstring in order to help allow that receiver be successful with that particular catch. And we talked about current training, and just about everybody in the room was familiar with the Nordic board, or that training tool where basically you fix the low leg, your tibia is relatively stuck, and you do a knee extension and then knee inflection against gravity in order to help train and strengthen the hamstrings. And so prior to the discussion of how the hamstrings needed to move, essentially the crowd in the room seemed to think that was a pretty good idea for training these athletes. But then we started talking about how the hamstrings actually needed to be able to function in order for that athlete to be able to bend forward and reach down towards the ground while running. We talked about how the hamstrings needed to be able to lengthen and create stability in a position where the hamstrings are in a completely lengthened position through hip flexion at the hip and through knee extension at the knee. And we talked about where, using the Nordic board, that hamstring's being trained. And it's being trained in a very shortened position in a fairly artificial way. The foot's not on the ground. You're receiving a cacophony of proprioceptive information from the joints. It's really a single joint moving when you think about a wide receiver going to catch a ball, needing input from the entire body. And so we started talking about how we could create more mobility and stability at the hamstring simply by, doing a hamstring mobility exercise, where you're standing there, your heel's on the ground, your leg is extended, and then moving your body over a relatively fixed leg in order to create the reaction in the hamstring that simulates functionally what's going on while the wide receiver is catching that ball. And I could see the light bulbs go on because we all stood up. We all participated in a movement that looked very similar to a wide receiver catching a low ball. And then we didn't have a Nordic board there, but we kind of thought about what the hamstring had to do in order to create that exercise where your leg's fixed and you're extending at your knee and coming back up. And I simply asked the people in the room, which do you think the athlete is going to appreciate feeling more like what they need to be able to do? And then which of these movements do you feel is more authentic to the individual and the activity that they want to be successful at? And so based on our evidence-based model, which exercise would be a better choice for this individual whose primary goal is to be able to catch a football without tweaking their hamstring? And I saw, like you said, a lot of light bulbs go on.
Yeah. I think that's a great approach simply because, it is something that kind of all of a sudden people got excited about because they said when you grab the ankles and the tibias are your knees are on the ground, and you lean forward, it is eccentric. And all of a sudden, so a great example is now we're going to study that. The problem is that it's eccentric decelerating knee extension, and the function of the hamstrings is eccentric decelerating knee flexion. And so not only is it so artificial and arbitrary to the body and dysfunctional to the body, it's actually the exact opposite of what you want to train the hamstrings to do. That's what's even more confusing. But if you just assume that, hey, because that's doing something eccentric and we're stabilizing, we're doing this, and we can even maybe put some sensors underneath that and maybe assess it, that objectiveness is going to give us the evidence that we need to see if we can train hamstrings. We forgot about that global evidence to start out with and say, well, the hamstring basically is a knee extensor, not a knee flexor. That's training it as a knee flexor. Well, that makes absolutely no sense to anybody that you would train a muscle to do the exact opposite. In fact, the proprioceptors would add a little context to that and say, in fact, I think if you train us to do the exact opposite, we're not going to be there for when you reach the football. In fact, we might even create the opposite response that will actually create the tear. Now, that's frustrating for people who maybe are doing that, but your example is perfect because you've got to start with the evidence of the truth of what the hamstring does out on a football field, and then see how close that particular technique is even to the truth. And there's huge gaps there, even to a gap where I would contend that the gap is so significant and the reaction is so opposite and contrary to what the hamstring needs in the rest of the body that I would even say the evidence to me proves that it's contraindicated. So that's a pretty aggressive statement, but the truth, the evidence of the function of the hamstring would kind of, I think, bear me out.
I would agree wholeheartedly. Although we did, as kind of a fun exercise, try and come up with a functional activity where using the Nordic board might be helpful. And the one suggestion, because again, there's no such thing as a bad exercise as long as it relates to what the individual wants to do. And so if you are helping to train or rehabilitate a trapeze artist, that might work really well.
Yep. So that's good. Well, I'd like to invite Doug back in because I think at least I have a better idea what evidence-based stuff is. But I think what we want to do is see kind of how we look at it with an AFS lens and begin to apply it so we can really see that, okay, enough of the jibber-jabber. What do you got for us?
Well, just in hearing the conversation, I get excited because when you talk about that regional interdependence, I'm smiling because I didn't realize it would take 45 years for it to echo back. Mm-hmm. I know you've been preaching it, and that's really the name of the game is we are truly chain reaction beings. But the process that Andrea just articulated so perfectly in talking through with movement professionals how the hamstrings really work and the light bulbs went on, she essentially walked us through the functional movement spectrum of applied functional science. And so when we're talking about how applied functional science provides a structure for evidence-based practice and what this looks like for enhanced outcomes for patients and clients, I love the confluence of the evidence itself, what's been researched to be proven true. I also love the experience, but it all comes back to the individuality. Mm-hmm. And it truly is a process that we need to understand how the body really moves. We need to, of course, base that on our experiences as movement professionals, but ultimately take a look at that individual and say, how does this body function? Because while there's a lot of similarities from my body to yours, to Andrea's, to someone else's, how you move is drastically different than me. And so we tend to say, protocols, while well-intended, aren't necessarily the best for the masses. Mm-hmm. They might be the best for the mean, but there's a lot of people on this side of the mean. There's a lot of people on this side of the mean. And if we're really going to enhance the outcomes for the individual, for our patients and clients, we need to go through a very similar thought process that Andrea just articulated. And we call that the functional movement spectrum, which just happens to be behind us. And the functional movement spectrum is a way to say, based on the evidence, what principles have been proven true, based on our experiences and the individuality of the person in front of us, how are we then going to apply those truths And that's what applied functional science is. This was the starting point of 3D maps, but this is the common thread to everything that we deliver to help us get to the best outcomes for our patients and clients at Gray Institute. And so I'm going to let you walk them through this, but we have this functional movement spectrum that takes the physical sciences and the biological sciences and the behavioral sciences, another 3 circles, and that confluence really becomes applied functional science. And based on what we know that's been proven true, really allows us to have even more aha moments as movement professionals to say, maybe we are doing an exercise now this way, but potentially, how can we tweak that exercise to make it more functional, not only for a specific context, such as a receiver catching the football, but more specifically to the actual receiver, the individual that's catching that football. So walk us through the functional movement spectrum, because that's going to ultimately set us up to say, wow, we're diving deeper into evidence-based practice, but ultimately, it's a lot of great words and talk. What does this look like specific to the hip?
Download the Gray Institute app for exclusive access to resources, training tools, and community. At Gray Institute, we pioneered the field of applied functional science. Now we're excited to offer exclusive updates on movement science, best practices, and other resources to our Gray Institute community of professionals. Our app offers practical tools that can improve both your practice and your client or patient performance. Our app offers powerful tools including access to the Home Fit app, exclusive community forum, webinars and extensive resources, and it's free to download. Download the Gray Institute app today, available from Google Play and the Apple Store.
Yeah, I appreciate that, Doug. In fact, I'm going to kind of not walk us through, but try to run us through. So, Andrea, I'm going to try to get through this efficiently, because if I'm watching this, I kind of want to know, show me the application, show me what you actually are going to do. But this is the evidence. So when people start talking about evidence-based, I start with, well, tell me so for example, how the hamstrings function. I want to know, first of all, how do they function? And how does the hip function? What does it do, and how does it do it? Let's start with that, and then you can start talking to me about evidence. So if you tell me that the evidence is this and this and this, and that all of a sudden you spend a lot of your time lying on your side, being artificially stabilized, doing a clamshell, I'm going to scratch my head and say, I'm sorry, you forgot the universal global evidence that says you have a huge gap there. Now, as you said, Andrea, theoretically, there's no bad exercise, although I think sometimes there is. But the more gap you have between what the hip really does and what the evidence is trying to prove to you to do, and not knowing that you have that gap, the whole chronic thing of gaposis, that's when we get into trouble. It's okay to be over here, very non-functional, doing something with the hip if you got a really good reason, but if there's a better way to approach it based on the pure evidence. So if you don't mind, please feel free to interrupt me, slow me down, grab my hip, and just tell me what I need to do different. This is, like I said, this is evidence. I would have given my eye teeth. I don't know what that means. I hear my mama said that. To have this early on in my career, to give me guidance as to what does that patient, what does that client really need. And the first 3 are what we call from the physical bucket of applied functional science. It's the physics of it all. And all this thing says is, if this is the activity, let's stick with our wide receiver, if you don't mind. Again, this applies to our 65-year-old person that's just struggling to kind of keep playing a little bit of paddle ball. And this applies to our 85-year-old person who just had a total hip. This applies to everybody, but if we kind of think of our wide receiver, we're going to call this running and cutting right here, because it's all relative to that. And the environment, to make it functional, should be natural. It's an open football field. As soon as you see stuff grabbing onto ankles, as soon as you see Velcro, as soon as you see artificial stabilizing things, take a step back and go, is that going to jeopardize the authenticity of this activity? And I'll give you a hint. Yes, it will. So that becomes very unnatural. Having somebody grab your ankles and leaning forward not only looks unnatural, Pooh Bear would go, what are you doing that for? If you've ever felt it, it feels totally unnatural. You've never felt that before. Big hint. Gravity and ground reaction force need to be used. That's why if you're talking about an upright activity, you probably should be upright in your assessment, and you probably should be upright in your training and your rehab. If not, there's probably a good reason, but you know you're going to have gaposis because muscles don't function the same and proprioceptors don't function the same and joints cannot function the same when I go from an upright posture to a lay down posture. Impossible. In fact, we've actually proven many times it's really the opposite again, and the hamstring's a great example. I can lay on my belly and contract my hamstring. It does become a knee flexor, but as soon as I reach for something, now that hamstring is a knee extensor, and it decelerates rotation as well as ab and adduction. So this is a big one. What's gravity and what's ground reaction force doing to that body, and how do I appreciate what in the world's going on at the hip? And perhaps the biggest one that I neglected for years is mass and momentum. We many times see too many things where we're assessing people just not moving. And we call it a movement assessment. No, the hip wants to move. If the hip would say to us, if you want to assess me, you got to assess me and allow me to do what I do, and I move. I move, I decelerate the motion, and I come back and I do something else. So that's what I do when I run. That's what I do when I reach for the ball. That's what I do. And so we have to go, does the movement assessment that we have, does the training that we're doing, does the rehabilitation that we're engaging in use mass and momentum of the body? It needs to, or we're not training the body to do really what it wants to do. As soon as you start slowing things down and trying to isolate things and say, don't move or grab this or lay down and lift your leg like this, you got to scratch your head and go, I'm sorry, there's a big gap there. It's not necessarily all that wrong, but it has nothing to do with the function as we're talking about today as the hip. These are no-brainers here. The hip moves in 3 planes of motion. We better have an assessment tool, therefore, to look at the hip in the sagittal plane with flexion and extension, ab and adduction, and internal and external rotation. Non-negotiable. In other words, if the hip is so powerful and it does so much good stuff, like you said, Andrea, to say, well, we're just going to look at maybe just the single plane and maybe just the sagittal plane and the flexion, we've missed everything. And so we realize we have to have an assessment and a training strategy to look at all 3 planes of motion. Oh, here's that word, chain reaction, interdependency. So if we're going to deal with the hip, we got to know what the foot's doing. We got to know what the thoracic spine's doing. We got to know what the shoulder's doing. As important, we got to know what the hip does to those things. And if we're all honest, we didn't learn a lot of that in school. It's kind of strange. When patients come to me 45 years ago, everything was connected. And it's still connected. Now we're finally realizing it's connected. So we have to understand how the connection reacts. This might be the biggest thing that Dr. David Tiberio, as you know, Andrea, has led us through over the last number of years, is really understanding what proprioceptors are there for. What they are, first of all, it's a magical tool. It's a miraculous tool in the body that takes mechanical force and transfers it into electrical force. It's like spooky that we have that in our body, but in the reality, instead of in school just memorizing the names, what Dave has taken us through is, so what do they do? And how do they do it? And talking about the hip, talks about the importance of getting to end range of motion, talks about the importance of the transverse plane, talks about the importance of kind of doing speed work. It talks about, the proprioceptors say, everything you're talking about, guys, is exactly what we want. As soon as you start going to this side, the proprioceptor says, you're turning me off. And the whole goal with everybody is to turn on as many lights, have as many light cells, as Terry Lewis said in our functional yoga, turn on as many kind of cell towers as we can in order to facilitate that. That's exciting when you finally realize that. Another really cool part is we now understand that muscles react to movement that turn on proprioceptors, and then the muscles turn on and decelerate eccentrically. So if you're turning on, in this case, the hamstrings eccentrically the wrong way, artificially stabilized with a piece of equipment, not utilizing gravity the way it should, not using mass and momentum the way it should, in all 3 planes of motion, you got to go, I'm not sure that's what I want. In fact, now I am sure it's exactly what I don't want. So we want to train all the muscles as reactors, not as actors. We don't want to put a dollar bill between somebody's crack and say squeeze, and that's how we turn on your glutes. It's kind of funny on one hand, but it's almost kind of sad on the other hand, because that's not how the body functions. And then, of course, we got the integrated joints now. Not only do we have this interdependency, but every joint is hooked onto other joints. When we talk about the hip is the knee and the foot. The hip is the other hip. This hip is the lumbosacral spine. This hip is the thoracic spine. And so you go, that's a direct connection. Impossible to talk about function of the human body and to look at the 3 planes of motion and the 6 predominant motions of the hip without looking at the thoracic spine and the feet concurrently if we really want to understand the hips. Therefore, we look at this big one. The body wants to function kind of subconsciously. I want to reach, I want to lunge, I want to reach for a ball. I don't want to be told, hey, do this, hold this back, find neutral here, do this with your hip. Think about that. That's not how the body functions. And so we want to have this task-specific conscious reaction into what we call transformational zones, which gets us into specificity. If I'm talking about the function of a hip in an activity, I want to know what the function of the hip in that activity is. So if I have somebody running really fast and I know this backside hip's got to really go through huge extension, huge internal rotation, and huge abduction all at the same time, I better have an evaluation assessment scheme to see that, and I better have a training scheme to reinforce that, or I'm going to be missing the ability of that backside hip to do what it needs to do to run and to sprint and to cut. So we take a look that the combined concept of, so what do we want all these joints to be able to do? We want them to have mobility and stability at the same time. That's why we came up with the word most stability. I like the word, even though we kind of made it up. It reminds me that mobility without stability is instability, and too much stability without mobility is a rigidity, which is an instability. We want a nice, mobile, stable body to move, and that's what we're after, especially when we concentrate on the hips. And the last 3, this is where I think you're a superstar, Andrea, is you really use this in order to encourage and build upon success. What's the success of your hips? Because if I can see some success in your hips in any of those 6 directions, I can build upon that, and I can then use the principle of 3D to accomplish things I never dreamed of. Instead of beating up what you can't do, show me what you can, I'll build upon that, and I'll build upon your success, because success begets success, and success gives me an opportunity to encourage you. Obviously, if we're getting the client and patient to do that which they do, they sense that this is like reaching for a football. Getting down on my knees and leaning forward doesn't feel like I'm reaching for a football. Immediate engagement. So if I have this hip and I know this hip has to flex, adduct, and internally rotate in order to hit a forehand and pickleball, well then I'm immediately engaged, because you just took me through those motions of the hip and the movement of the body that smells like what I just told you I want to do as an individual, what I need and what I want. And so that engages you, and then the ability to go, hey, you know what? You're empowering me to take care of myself. This makes so much sense. The progressions build upon success never put me at risk. I don't feel like I'm unsafe. And the patient and client go, thank you. I thank you for starting with the real evidence that makes sense to me, as opposed to going to this evidence that, I'm sorry, I thought you were the professional, and that doesn't make sense to me. I don't want to argue with you, and I don't want you to show me the article that kind of showed the fact that it ignored the global evidence. But patients and clients want us to basically love and respect them, and to basically reinforce what they say they want to be able to do. I want to be able to walk. I want to be able to lift. I want to play pickleball. I want to do something so my back's not hurting. I want to be able to not have to limp. They'll tell us what they want. We have to look at the evidence and go, this is the best way I can give you that gift. So I went a little quick. I get excited about this because it's undeniable truth. We've never had, so far, over the last number of years, no one's come up and says, nah, you don't have to worry about gravity. You know, sometimes it's not even there. Or ground reaction force, overrated. All these are universal evidence, truth, that, as Doug said, leads to our strategies, that leads to the techniques that we need to look at the evidence. If you don't know this universal truth, you wouldn't look for a hip dysfunction for a plantar fasciitis. Because you wouldn't know the interdependency between it and how you would actually get the hip to talk to the thoracic spine, to get the foot to do what you want to do, to lock it up sooner so you take off the stress of the plantar fascia. And so we kind of kind of boils down, we have to know our AFS, we need to know our chain reaction biomechanics. I don't know if you want to add anything as I invite Doug back in, Andrea, but I kind of went, I think, a little wild on that one.
Ask yourself, are you looking to reconcile differences and inconsistencies in your movement education? Do you desire to know more about how the body truly functions, how it truly moves? Are you treating or training causes or just the compensations? Do you want to be able to treat or train any and every patient or client effectively? Are you looking to rejuvenate your career, enhancing your passion and purpose? Do you want to share an experience with other passionate movement professionals? Gift Gray Institute for Functional Transformation. Transform your career and transform your patient and clients' lives. We're proud to offer 2 program options for GIFT 2022. GIFT Fellows will have the opportunity to complete their fellowship entirely online or to attend 2 GIFT gatherings in addition to their online mentorship. This will provide GIFT Fellows with the flexibility they need to stay nimble in our ever-changing world. GIFT is a 40-week mentorship program in applied functional science. GIFT provides certification in functional manual reaction as part of the 40-week mentorship program, as well as being credentialed and recognized as a Fellow of Applied Functional Science. An FAFS has the knowledge, analytical ability, and hands-on manual skills necessary for the application and integration of the core content of the GIFT curriculum, thus strategically designating you as a member of a select group of practitioners synonymous with the highest standard of care in the functional analysis of human movement. The program begins Thursday, February 3rd, 2022, and concludes the week of October 31st, 2022. Apply now at grayinstitute.com.
Hey, that's all right, because I could not agree more. I think the functional movement spectrum speaks to evidence-based practice. It is when you look at the spectrum, when you consider the individual in front of you, I think the most powerful thing that you said when you address the bottom 3 criteria in the functional movement spectrum. In this day and age in medicine, the average interaction time with medical professionals or, physical therapists or movement professionals is consistently diminishing. So exactly what you said, if you create an assessment and if you create a movement intervention that resembles the activity that they want to get back to doing, those individuals feel heard. And they feel empowered, exactly what you said. And they understand that you're there to help them get to those activities that they want to be able to do. And as you said, their buy-in is immediate. They understand that what you're asking them to do is going to help. And to be perfectly honest, it makes it a lot more fun. If you're training for an activity that you love doing and your training itself and your assessment and your exercise resembles what you love to do, it makes it that much more enjoyable to follow through with your home exercise program or with your daily training than doing an exercise that just doesn't feel like it's going to do you any good. And sometimes, as you mentioned previously, sometimes it just hurts or just doesn't feel good. So I think you speak to the brilliance of the functional movement spectrum. That is evidence-based practice.
So let's get on with it. We have the truth, the evidence. The evidence kind of drives our strategies, which we've kind of outlined strategically. Here's what we want to accomplish. So if we're just talking about the hips right now, what does that look like? So Doug, would you mind just take your time, but take us through, okay, based on all this, if we're going to assess the hip, we're going to follow every one of these principles, and we're going to assess the hip, and obviously I have to figure out all 6 directions. So I'm going to kind of literally, just so I don't kind of get in your way and inhibit you, I'm going to step off for a little bit, because I want you to just take a little time to walk us through it, and then when you're ready to allow Andrea and I to jibber-jabber a little more, you can invite me back on. Is that a deal?
Okay, well,
all right, good luck.
I don't know what just happened, but I feel like I'm ready to run through a wall. That was equivalent to a pregame speech where we're going to go out there and we're just going to annihilate the other team. But instead of this case, we're not going to annihilate the other team. We're going to empower the individual in front of us by how this all applies. And so we're now into that third big rock of chain reaction, biomechanics, and the movement solutions for the hip, the anterior hip, posterior hip, medial hip, and lateral hip. And where we're going to start, of course, is what Andrea already introduced us to, and that's 3D maps. three-dimensional movement analysis and performance system. And when you think of the word analysis, of course, testing comes to mind, or assessment. And there's a cute phrase out there that if you're not assessing, you're guessing. I would agree with that, but I would say, whoa, it's a little incomplete. And of course, like representing Gray Institute, we're going to tweak that phrase and say, if you're not assessing with 3D maps, you're not only guessing, you're missing. And we don't want to guess nor miss because we ultimately want to empower that patient and client in front of us. And the reason I can say if you're not assessing with 3D maps, you're guessing and missing isn't by just what I'm saying, it's what Gary just walked us through. Because it's this functional movement spectrum that was the starting point of 3D maps. We didn't take some traditional physical therapy movements that have been quote unquote accepted in the industry and say, let's try to make sense of these. We said, let's not be complacent with those, but let's say, based on the evidence in our experience and how the individual in front of us moves in real life, what's going to be the best movement to apply all of this? And strangely enough, it's that behavioral science of encouragement, empowerment, and engagement that really wins out. That we want that individual to be successful in his or her movements. We want that individual to feel empowered by an internal locus of control with those movements. And we want that individual to be engaged because, as Andrea said, we're using movements that they can feel successful, but more importantly, they can sense the relevance to how it applies to everyday life. And since we're talking about the hip, that's another great place to start because from a biomechanical standpoint, we know that the hips have 6 degrees of freedom. In the sagittal plane, it can flex and extend. In the frontal plane, it can abduct and adduct. In the transverse plane, it can externally and internally rotate. Well, all joints have 6 degrees of freedom, but some joints, relatively speaking, don't have a lot of degrees in one plane compared to the other plane. But if we're looking at the hip, we ultimately want to say, if we're going to facilitate those motions at the hip, we now know, of course, that it's the motions at the joints that then turn on the proprioceptors and allow the muscles to react. And that's how they happen in everyday life. So with 3D maps, we ultimately want to move in a manner that allows the hip to demonstrate its successful ability in all 3 planes. And it just so happens that these movements of 3D maps not only allow the hips to demonstrate its success in all 3 planes, but all the primary joints of the body. The subtalar ankle complex, the knee, the lumbar spine, the thoracic spine, the cervical spine, the shoulders. And when you kind of add up all those motions together, in 6 simple movements, 66 motions are highlighted. But we really want to focus on the hip and how we can allow all this principle-based information to be applied with movement. So with 3D maps, we simply start people out and we go ahead and lunge forward and we lunge backwards. We lunge to the same side. We lunge to the opposite side. We rotate to the same side and we rotate to the opposite side. And of course, Gray Institute's been known as the lunge people for years, but we're really the matrix people, that if we're going to do something in one direction, let's go the other direction in that plane and make sure all 3 planes are covered. Well, that allows us to now start to warm up the body. And after we teach someone the lunges, we say, you know, what's another driver of the body? Well, our hands. And we can drive our hands high and back, forward and down in the sagittal plane. We can go to the right and we can go to the left in the frontal plane, and we can rotate to the right and we can rotate to the left in the transverse plane. But if you were to put a spotlight on my hip through the lunge matrix, as well as the bilateral hand swing matrix, you would see that those drivers facilitated an authentic chain reaction to allow the hip to move in all 3 planes. Where the plot thickens and it gets more exciting is when we combine those movements together. And these movements combined become the mobility analysis movements of 3D maps, where in 6 movements, All 66 motions of the body are demonstrated in a successful manner, but what's great is you can automatically feel the enhancement of those movements with how you move, whether you walk, whether you run, whether you are going to catch a football, because we're getting the joints to move in all three planes, which means we're getting the muscles to be turned on in all three planes, and in the process, we're turning on as many proprioceptors as possible. So I said if you feel it. So if you feel compelled, go ahead and get up with me right now and just kind of feel this as we go through the 6 chain reactions of 3D maps. So with your right foot, all you're going to do is lunge forward and then swing your hands high and back, and then do the same thing with your left foot lunging forward and swing your hands high and back, and that's just the anterior chain reaction. Posterior chain reaction, we're going to lunge backwards and we're going to swing our hands down and back. So take your right foot and lunge back and swing your hands down and back. And same thing with your left foot, lunge back and swing your hands down and back. And we're just going to allow the eyes to follow the hands because it facilitates the chain reaction that we desire. Now we're going to move in the frontal plane. So you can start with your hands up, and with your right foot, just lunge to the right and swing your hands high and to the left. And then with your left foot, lunge to the left and swing your hands high to the right. And we call that the same side lateral chain reaction. Now we're going to crisscross with our lunge in the frontal plane. And so with your right foot, lunge to the left and your hands swing to the right. With your left foot, lunge right and your hands swing to the left for the opposite side lateral chain reaction. And now we're going to twist and shout a little bit in the transverse plane. So with your right foot, you're going to rotationally lunge back and keep your hands following your foot as you go right rotational. The same thing with your left foot going left rotational for that same side rotational chain reaction. And last but not least, we're going to take our right foot, lunge rotationally to the left in front of our body, allow our hands to follow. And with your left foot, lunge to the right rotationally with your hands following your lunge leg. And automatically you feel like I can move just a little bit better. But from a biomechanical standpoint, when we went forward, we exposed our hip from a mobility standpoint to its functional end range of motion from extension. When we went posterior chain reaction, we facilitated flexion. When we went same side lateral chain reaction, we facilitated abduction. When we went opposite side lateral chain reaction, we facilitated adduction. When we went same side rotational chain reaction, we facilitated external rotation. And when we went opposite side rotational, we facilitated internal rotation. All that to demonstrate its ability, but those movements aren't just arbitrary. They follow the functional movement spectrum. So if we're really going to try to assess someone for global human function that really relates to any sport, task, or activity, we're going to use a natural environment. We're going to use gravity and ground reaction force, leveraging mass and momentum. Make sure the motion is three-dimensional, that the body operates as a chain reaction, that the proprioceptors are facilitated, that all the muscles are reacting, the joints are being integrated. The task elicits a subconscious reaction. The transformation or specificity allows for that change of direction. Mobility and stability are utilized, as well as success, movements, internal locus of control, and relevance allow us to be encouraged, empowered, and engaged. Well, what's great about that is now that I'm getting just a little bit older, those quote-unquote mobility analysis movements are starting to kind of teeter-totter more towards the stability part for me and my body. So maybe 10 years ago, there's a lot more mobility involved, but if I was even older than I am now, those quote-unquote mobility movements might be more emphasized on stability because they're individualized to that person in front of you. But if we wanted to take that teeter-totter and say, let's put more effort on the stability aspect of those movements, we go right into the stability analysis movements of 3D maps, where that lunge now becomes a toe touch to no toe touch, and you can see now that the same motion in that anterior chain of extension is facilitated, but now my body has to control that motion more, emphasizing more of the stability analysis movements. Well, that simple tweak of a toe touch to no toe touch is how we progress the posterior chain, the same side lateral chain, opposite side lateral chain, same side rotational chain, and opposite side rotational chain, because we know that mobility and stability is one coin, just both sides. And so we not only want to make sure that the motion is available, but we want to make sure that that motion can be controlled, not just at the hip in this case, but we know that the hip is going to be influenced by what happens below it and what happens above it. So the same 66 motions that are covered in the mobility analysis moment movements are covered in the stability analysis movements, but now we have more of an accurate picture of how this individual moves, where he or she likes to move, where he or she maybe doesn't like to move as much. And throughout the performance system of 3D maps is we leverage that process to say, let's start where they're successful. Not what they can't do, but what they can do. Because if we can shine a light on what they can do with the process of applied functional science, we're going to allow those successes to start to feed those quote-unquote unsuccesses, which is why we build that into the performance system. So with 3D maps, the great thing is it really allows us to hone in on the big rocks of the body as well as the entire body. Like, let's start with the hip. But now, what is that subtalar ankle doing? Now, what's the knee doing because it's caught in the middle? Or what's the thoracic spine doing, and how is that influencing the low back, the upper back, as well as the shoulders? And we start to realize that there's regional interdependency built into 3D maps, whether we can connect the dots just yet or not. It's the performance system through how we assess and what the outcomes are that allow us to begin to learn that even better so that we can ultimately help the individual in front of us. So when we really look at the hip, we look at this functional movement spectrum to say, all right, guide us on what we should be looking for. Well, how well does it move in all three planes? Is the motion there? And can that motion be controlled? And can that motion be controlled in conjunction with the entire body? And so based on that, we can go ahead and say, what's going to be the best process to help the individual in front of us? Now, here's what also allows us to understand more about this hip. That even though we're going ahead and lunging forward to look at extension of the body, this really looks like when I'm walking. And not only is extension coupled with abduction, but it's coupled with internal rotation. But I can get a better look at abduction with that same side lateral chain reaction, and I can get a better look at internal rotation with that opposite side rotational chain reaction, but I start to understand how the hip really moves. So if I'm looking at that anterior hip, I also want to facilitate not only extension, but I know that maybe at the hip flexor might be known as that extensive muscle. Well, it gets lengthened more with ab and adduction as well as internal rotation. So we know that all muscles function in all three planes. If we're looking at that posterior hip or back there, that talk about the hamstrings really comes into play. And not only do the hamstrings get lengthened with hip flexion and knee flexion, but where do they really get hurt? Well, when we're kind of changing direction, and changing direction means that the hip and the knee is going more towards the frontal plane as well as transverse plane, so the hamstrings are a triplane muscle. Well, what happens when we look at kind of the lateral hip? Well, the lateral hip, we like to just say, is really kind of that posterior lateral hip, or we really just call that the back button applied functional science, which means not only does it get turned on with adduction, but with flexion and internal rotation as well is really how we attack that outside or that lateral hip. Therefore, that inside hip or the medial hip does get lengthened with abduction, but we also call this the front butt. That's really the anterior medial butt or the hip, which really says it's extension, abduction, and external rotation. Well, that's where we get kind of a layer deeper where maybe we take someone through 3D maps and we take them through the performance system and we know that maybe part of the hip is gunky. It might not be in pain, but it's gunky and it's dysfunctional. We might want a more direct approach in how to attack it. So before I walk you through another progression of the anterior hip, I'm going to ask Gary to come back here on the stage here, because what I want him to do is give us an idea of how 3D maps and CAVS, our certification in applied functional science, are different, but also how they're very similar and how we can use them both in the process of progressing an individual based on his or her functionality, but more importantly, how we can directly affect the hip to influence that individual.
Well, Doug, you just did a wonderful job with that. I was kind of over there, and so now that we run over to the door to get out to the field, I think we competed quite well. I love the idea of what we're just trying to do And again, Andrea does a beautiful job with this. When I see her evaluate people, she steps back and gives that body an opportunity to show them what they can do. Like you said it beautifully. I just want to see a picture of how their body moves every which way it can possibly move. Once I have an assessment there, we basically go, I now know what to do to build upon. The whole reason you assess is it's going to determine what you're going to do next.
Right.
If you already know what you're going to do next, don't waste your time on the assessment. If you got a protocol in front of you and you think, well, I'm just going to do that no matter what, then I would suggest, but that's not giving it our best. That's not understanding the person in front of us. The beautiful thing about what we, I think, have done at Gray Institute is we did it, as my mama would say, back-assward. We started years ago with all the principles and truths and strategies and kind of looked at everything and all the interconnectedness and came up with this chain reaction biomechanical analysis. And then we were able to say, well, we got to kind of zoom this down a little bit and to get a little more isolated while integrated, very key phrase we'll talk about. But then we wanted to say, but then how do we look at the whole body in 3D maps? And so the progression is a very logical progression, but not on the surface. You'd go, wait a minute, it would have been nicer if you started with a real good evaluation 45 years ago of 3D maps and then got to where you're going. We could have not done that. We weren't smart enough. We just didn't know the truth of human movement that well back then. And so calves and 3D maps are very similar because they build upon each other, but they're different because calves says, okay, I do know in this case, and Andrea will tell you the same thing, and I know when you evaluate the same thing, we look at the picture. I love the way you just said it, because we're looking at the shape. So in the anterior chain, it's not unusual at all that I see pretty good dorsiflexion, pretty good thoracic, sometimes too much lumbar extension, kind of that binding, but the hip's not letting go. And we know why, because we've been sitting most of our life. We got gravity that's driving us into that motion. And most people don't know how to lengthen their capsule as well as the iliopsoas in 3 planes of motion. So we got these, as you said, I like the word gunky hip. And so we'd go, well, 3D maps takes us through a progression that uses the integration of the whole body and hybrids and different positions and different drivers to facilitate getting that motion. But a lot of times, as you said, we want to go right after it. And so calves allows us to go right after it. So what I'd like you to do, if you don't mind, is kind of go jump back at it and take us through an example. And I think this is a very powerful one because you'll see this client, this patient, over and over and over again who doesn't have a good extension mobility and good extension stability of the anterior part of their hip, where you go, well, that's kind of cool. We're starting still integrated, still very functional, but isolating a little bit. And as we decrease our isolation, we get a little more integrated. And if you wouldn't mind taking us through the 4 layers that not only we do for the anterior hip, but in calves we do for the posterior, and as you properly said, medial and lateral hip, as well as every other joint in the body.
Right.
Would you mind taking us through that real quick?
I'll try to fly through that because this right here, of course, is hopefully continued gold the way you're hearing it. But in this solution, we said, you know what? The anterior hip is gunky. It's not in pain, so that right there immediately is a strategy for me that says, you know, with this individual, I know he or she can handle it. Let's just kind of go directly after it. And you're going to find that within that anterior chain, that if we kind of go ahead with a corrective exercise approach, which really calves is founded upon, that we're really going to isolate the part that we want to go after. But the progressions within calves allow you to then integrate that joint with the rest of the body, because we ultimately got to have all these boxes checked off within the movement progressions. So the first thing that we do in calves when we look at that anterior hip is we kind of realize what I already mentioned about kind of that hip flexor, if you will, that it gets turned on with extension. But it also gets turned on with abduction as well as internal rotation. So with that knowledge of the chain reaction biomechanics, if I'm going to go after my left anterior hip, I'm just going to do a left kneeling starting position. And right now I have an extended hip. What I'm going to do now from this position of kneeling is I'm just going to go ahead and take my pelvis and I'm going to drive it forward and back, side to side, and I'm going to rotate it to cover kind of that pelvic drive matrix. And if I don't have back pain, or even if I do, I can still operate in ranges that don't trigger the pain, I'm going to say, can I facilitate more motion at my hip while getting my thoracic spine involved? And now what I'm going to do is drive my hands down and back, high and back. Whoop, I think you saw those movements in MAPS. Or I'm going to go side to side, and you saw those movements in MAPS. And I'm going to go ahead and rotate, which you saw those movement in MAPS, because if I can gift that anterior hip and not just the sagittal plane of extension, but especially with abduction and internal rotation, I'm going to allow that front hip to function better in all three planes. But that's just progression 1 in calves. That ultimately, I have a very stable position right here, which allows my body to demonstrate more mobility. Ultimately, I got to take some of that stability away so that I can start to not only incorporate the rest of the body, but start to tip that teeter-totter more towards stability. So the second progression of calves, and I apologize right now, I'm going to show you another bad side of me, but I'm just going to face away from you, and I'm still going to go after that left anterior hip. But in this case, instead of kneeling, I'm now going to do an elevated position, which actually is a part of 3D Map's performance system as well. But I'm going to do that same progression that I'm going to take my pelvis and go forward and back, side to side, and rotate. And then I'm going to take my hands and do the same thing, swinging in the sagittal plane, the frontal plane, and the transverse plane, only in ranges that, of course, make the most sense to my body. Now, with all these positions and movements, we can tweak it. So, for example, I could take my right foot and go a little bit wider. I can also take my right foot and go a little more narrower, which allows me to bias my hip in more an abducted position or an adducted position, depending on how I want to continue to challenge it. But that's the second progression of calves. The third progression now is take away a little bit more stability so that my body can start to demonstrate more stability. So we get back into that natural open environment of just being in an upright stance here in the room. And I would actually do a series of lunges where I could go anterior, I'd go same side anterior lateral, and I'd go opposite side anterior lateral. So I'm really emphasizing extension. Now I'm getting some abduction and internal rotation. Then when I get in this transformational zone, still getting extension, which a lot more abduction with internal rotation. And then with opposite side lateral, lunge while going forward, still getting a lot of extension with more adduction and internal rotation, knowing that that's how my hip gets turned on. That'd be progression 3. And then finally in progression 4, I would do that same lunge of forward, going forward to the right and going forward to the left, but I would do that with a posterior overhead reach, a same side lateral overhead reach, and an opposite side lateral overhead reach with all three lunges to continue to not only isolate the hip, but doing it now while integrating it with the rest of the body, where the foot's involved, the thoracic spine's involved, the shoulders are involved, the entire body's involved, because that's how the body truly moves. Now, think about that, not only with just the anterior hip, but with the posterior hip. I could just kind of demonstrate what happens from a kneeling standpoint, and you can then start to piece together how you would progress it. But from a posterior hip, I could go ahead, and I'm going to go ahead and do a right kneeling, because now it's my up leg that I'm really going after from a hamstring standpoint, because I need the hip to be flexed, the knee to be flexed, and I can do the same thing with my hips going in all three planes, same thing with my hands going in all three planes, and that sets the structure and how I could progress it. Think what you can now do for the lateral hip. If I was going to go after this down hip from a lateral hip standpoint, I know that the lateral hip gets lengthened a lot with adduction and internal rotation. So I'm going to narrow up my kneeling, and I'm going to actually internally rotate my left foot to internally rotate more of my hip. So I get a lot of adduction and internal rotation now with driving the hip in all three planes and the hands in all three planes. And then you already know where I'm going with the medial hip. If I need more abduction with that extension and some more external rotation, I'm going to go more from a wide standpoint, which really exposes this hip, especially in the medial side, especially in the frontal plane. And from this now right kneeling standpoint, I'm much more wide and I'm externally rotated to really expose that hip, drive it forward, back, side to side, rotate with the pelvis. Same thing with the hands in all three planes. And that sets the structure and how we would then build when we get off the ground in an elevated stance to an open room of lunges, and then factoring in the hands. And you can just imagine what type of gold is in calves. But more importantly, it replicates the biomechanics of how the hips really move. But more importantly, not just how they move from an isolated standpoint, but more importantly, from an integrated standpoint. So, Andrea, I'm going to tee you up here real quick because I've been talking way too much. Gary's been talking the right amount. You've been talking not enough. So you got to give us kind of a synopsis of what in the world you just watched and really what that means from an evidence-based practice standpoint.
Okay, absolutely. So, Doug, thank you very much. I think that was a fabulous illustration of going from a more isolated approach to addressing potential mobility and stability limitations at the anterior hip, going from the half kneeling to the standing progression. At the same time, you're going more locally at the hip and then integrating it more globally into total body function, which again is exactly what the people who are trusting us with our care are looking for in order to be successful. And it's just really exciting just watching you go through that progression. You hit all the highlights on the functional movement spectrum on the functional side of things. You know, functional has been a buzzword for a really long time, but when you really break down and analyze what function truly means, you just demonstrated it for us. And so I thought that was just really, really great. I think we're in an exciting time. You know, right now, as far as evidence-based practice goes, you know, we have a solid foundation in, you know, our clinical experience, Gary, as you said, over the last 45 years, we have a truly solid foundation. The core of AFS is helping to address the needs of the individual who's in front of us. And, you know, it's exciting because the best available research, the best available evidence is a constantly evolving body of evidence. And we're at an exciting time. You know, this body of evidence is somewhat catching up. You know, you hear regional interdependence or, you know, as the Gray Institute's been saying for decades, chain reaction. With advances in technology, with advances in looking at different study designs, you know, other areas in like education and more behavioral based medical professionals, they're starting to look at the value of other study designs that aren't quite as valued in the physical therapy profession, which is fantastic. So we are just really at an exciting time, I think, as this final circle and evidence-based practice continues to evolve. It's really just going to help support everything that you just shared and everything that I've been so fortunate to learn through the Gray Institute over the years. So we'll just appreciate that very much.
Well, as always, I asked you to do something and you didn't do it right. You did overly right. So that synopsis was amazing. And that's just a reflection of you, Andrea. But I really appreciate not only your contributions to this webinar, but your contributions to that process that you just talked about, that it truly is an exciting time. And what makes it so exciting is that I believe we're all a part of this amazing movement profession that cannot be happy with where we're at. But our patients, clients, athletes' lives truly depend on what we're doing. And while we're doing great things right now, I think we can do greater things by upping the standard. And a lot of that deals with, of course, understanding the research that's in front of us, the evidence, but also basing that off of our experiences, but also taking into account that we have an individual in front of us that doesn't move like anyone else on this earth. And it's our job to allow him and her to move better. And so you have had a huge hand in that, Andrea, as you've had a great hand in this webinar. So on behalf of myself and Gary and the entire Gray Institute, and definitely those awesome movement professionals that are watching this, we just want to say thank you.
I just want to echo that. Probably the biggest heroes here are the people watching this because they do want the evidence. One of the words that I like to use instead of evidence is science-based because it should be the same word. Evidence-based means if I'm doing something and Andrea asked me, why am I doing it? I should give you a good biomechanical, scientific reason why I'm doing it. And it can't be, well, I read about it or I got certified in it or somebody sold me this product and they told me how to use it. It's got to be evidence-based, a better way to say it, should be science-based. And that's the journey that Andrea's been taking us on for years. Dr. Dave Tiberio has taken us on for years through the whole Gray Institute platform. So I just want to thank you. You did a great job. Let's be open and honest here. The purpose of this is we believe if you're not already 3D map certified, it just makes sense that you would be, because we truly believe that it's the best way to assess the body based on the evidence and based on science. We also believe you should be CAF certified, because now you'll have multiple solutions besides the performance system of 3D maps to help someone move better, and that's why they come to see us, to move better. So on behalf of myself and the entire Gray Institute, Andrea, thank you so much, as always, superstar, and you just have just a special way to be able to describe things. And Dougie, as always, every time I listen to you, I realize how much you're able to put this together and spit it out even better. So wonderful job. Thank you.
Well, thank you, and thank you, amazing viewers.
Thanks for joining us here on the Gray Institute podcast. At Gray Institute, our goal is to do one thing the best we can, and that is to help you become the go-to movement professional. If you have a question for future podcasts or questions about anything Gray Institute offers, including education, live or online specializations, or mentorship, please email us at info@grayinstitute.com. Be sure to look for our next podcast coming soon. Have a great day.